Hello there, welcome to Dentlect, your exclusive dental lecture series. Today we'll be seeing about white lesions of the oral mucosa. To begin with, why do you think oral mucosa appears pink in color? Let me make it simple for you. Normally, the human skin and the oral mucosa is translucent, meaning the covering epithelium is translucent. It simply allows the light to pass through this translucent epithelium. There are 4 biochromes or pigments in our body. The first one is oxyhemoglobin, which gives the tissue red in color, reduced hemoglobin, which gives the blue color, and the melanin, which gives the brown color, and finally the lipofuscin, which gives the yellow color. So thus, the normal oral mucosa appears pink because of the reflection of the light striking the capillary bed. Now you know why the oral mucosa appears pink. Let's talk about the pathologies. We are going to talk about the white color of any oral lesion. It can happen because of 4 reasons. Number 1, hyperkeratosis, increased keratin deposition on the stratum corneum. Number 2 is increased fluid accumulation, which leads to edema or fluid buildup. Number 3 is reduced vascularity when the blood supply to the tissue goes down. And finally, pseudomembranous formation, which causes a coagulation of surface proteins. We can broadly classify the white lesions of oral mucosa into normal variations, hereditary white lesions, reactive or inflammatory white lesions, and finally infectious white lesions. Let's look into the normal variations of oral mucosa. We have leukoedema, Linea alba, and fordyces granules. So, to begin with, what is leukoedema? Let's split the word. Leuko means white and edema means fluid collection. So, this is the second reason which I told you previously. There is fluid accumulation in the stratum spinosum layer of a non-keratinized stratified squamous epithelium, which makes the lesion appear white. I wouldn't call this a lesion, but a condition which makes it appear white, because this is an anatomical variation and not a pathology per se. So, when you look at the oral mucosa, it will appear whitish as shown in this first picture, and subsequently, when you try to stretch the mucosa, it disappears. This veil-like appearance on the buccal mucosa disappears. But when we leave it back to becoming the normal mucosa again, then this white lesion appears back again because of the fluid accumulation back into the spinous layer. Moving over to the second condition, which is called as Linea alba. This is nothing but a horizontal streak which you can see along the line of occlusion on the buccal mucosa. It starts somewhere from the commissure of the lips until almost the last posterior teeth, and it's usually present bilaterally. And then the next anatomical variation that we are seeing is fordyces granule. We all know that the sebaceous gland is otherwise called as sweat glands is normally present on the skin. However, sometimes these can be present in the oral mucosa, so we call it as ectopish sebaceous glands, which causes this yellowish whitish appearance. The most common location of fordyces granules is the vermilion border of the lip and buccal mucosa. They are non-functional and does not require any treatment. For a fact that any of these normal anatomical variations, such as your Linea alba, leukoedema, or fordyces granules, does not require any treatment. Now that we have finished with the anatomical variations, we are moving over to hereditary white lesions. We have examples such as white spongy nevus, Dyskeratosis congenita, and hereditary benign intraepithelial dyskeratosis, or otherwise called as a whitkops disease. The first one is white spongy nevus. This is an autosomal dominant disorder that usually affects the non-keratinized stratified squamous epithelium, the most common location being the buccal mucosa. It is usually bilateral in appearance, and it has a spongy, velvety, plaque-like kind of lesion. And this does not require any treatment or intervention per se. The second one is Dyskeratosis congenita, which is a rare X-linked recessive disorder. And this will have a typical appearance of dystrophic nails, hyperpigmentation of the skin and face, and even the chest. The patients also exhibit oral changes before the age of 10. They have appearance of white ulcerated necrotic mucosa. Commonly affects the tongue and the buccal mucosa. The problem with this particular condition is that there are features of pancytopenia, Fanconi's anemia, and also carries a risk of carcinoma. The next hereditary lesion is your hereditary benign intraepithelial dyskeratosis, which is also known as whitkops disease. This is an autosomal dominant disorder which has a typical appearance of thick corrugated velvety plaques commonly seen on the buccal and the labial mucosa. And these kind of oral lesions tend to appear in the first year of life, and it keeps increasing in intensity until the teens. On the eyes, there is involvement of the bulbar conjunctiva into a gelatinous foam opaque plaques as shown in this first picture here. These patients tend to have ocular irritation and photophobia. Oral lesions does not require a treatment per se, but the ocular lesions require referral to the ophthalmologist. That was all about the hereditary white lesions. Now we are moving over to reactive or inflammatory white lesions. These are as follows. Let's take it one by one. So the first in this category is frictional keratosis. So as the name suggests, a keratosis or an increased keratin deposition because of friction or mechanical irritation. This mechanical irritation can be because of overhanging restoration, maybe a clasp from a removable prosthesis, orthodontic brackets, or any other source of intraoral mechanical irritation, and thus it's most commonly seen in the posterior buccal mucosa. The white lesion per se does not require treatment, however, it will disappear upon treatment of the source of mechanical irritation. So the second lesion that you're going to see here is chemical burn, which is a non-keratotic white lesion that can occur due to various chemicals such as aspirin, silver nitrate, hydrogen peroxide, sodium hypochlorite, or certain mouthwashes. These chemicals tend to give a wrinkled appearance on the mucosa along with pseudomembranous formation, which can contain necrotic tissue and exudate. So the treatment here lies in identifying the chemical responsible for the burn and eliminating such that the lesion can resolve by itself. The third condition in this category is actinic cheilitis. Now let's split the title. The word actinic means exposure to sunlight, and the word cheili means lips, and the word itis means inflammation. So prolonged exposure to sunlight, which is seen in certain occupations such as farmers and sailors, and hence the name farmer's lip and sailor's lip, can cause a kind of blurring at the level of vermilion zone, or maybe even ulcers if left untreated. So this is typically seen in more in males who are over the age of 45 years of age. So we have to suggest them to be away from the peak sun time during the afternoon hours, encourage the use of lip balms and sunscreen, and if the condition is already full blown, then vermilionectomy is suggested for severe cases. The next condition in this category is tobacco pouch keratosis, which is caused by smokeless tobacco usage. So based on the location where the smokeless tobacco is placed, it's commonly seen in the anterior mandibular vestibule and sometimes the posterior buccal vestibule. The surface of the mucosa appears grayish white and wrinkled, and it can be associated with gingival recession and periodontal bone loss of the adjacent teeth. The problem with this pathology is that it carries a high risk of malignant transformation. But simply stopping the habit can reverse this condition. Now let us see about nicotine stomatitis. It is otherwise called as smoker's palate or stomatitis nicotina palatini. As the name suggests, it is seen in smokers. Smoking such as cigar, pipe, cigarettes, or reverse smoking. Since the smoke and the heat of the nicotine first hits on the palate, the most common location of this condition is the palate, which appears as red pinpoint spots or papules, which represents nothing but inflamed ducts of minor salivary glands. Simply cessation of the habit can cause reversal of this condition. Moving over to a very important white lesion, which is the leukoplakia, which is defined as a white plaque of questionable risk, having excluded other known diseases or disorders that carry no increased risk for cancer. This is a white plaque and commonly seen on the buccal mucosa followed by the tongue or the labial mucosa. It's a non-scrapable white patch and it has been associated with smoking habit. It's predominantly seen in the males in the fourth decades of life, and it usually starts from the commissure of the lips and it can proceed posteriorly. Typically, the clinical appearance is being described as a cracked mud appearance. The next condition is oral lichen planus, which is a chronic inflammatory immune-mediated type of disease which can affect the skin and the oral mucosa. It is commonly occurring in the middle-aged female, and stress has been a very important predisposing factor. On the skin, it is described as a purple pruritic polygonal papule, and on the oral mucosa, it has a typical white fine lace-like pattern, and it is called as whitkops. There are several oral appearances such as reticular, annular, erosive, bullous, and the ulcerative type. Of all these types, the erosive lichen planus tends to have more of burning sensation. There are features of gingival desquamation, and it has potential to turn into malignancy, and hence very important. The very characteristic feature of oral lichen planus is that it has a bilateral presentation and the presence of whitkops. Being an inflammatory condition, they respond to topical steroids such as triamcinolone, clobetasol, and betamethasone. Coming to the next condition, which is oral submucous fibrosis, which is another potentially malignant disorder, just like your lichen planus and leukoplakia. It is a chronic insidious disease that affects any part of the oral mucosa with fibroelastic changes in the lamina propria and epithelial atrophy, leading to stiffness of the oral mucosa with progressive inability to open the mouth and eat. So these are some of the clinical signs and symptoms of submucous fibrosis, which initially begins as blanching of oral mucosa, burning sensation, and sensitivity to spicy foods. There can be dryness of mouth, progressive inability to open the mouth, because when you try to palpate the buccal mucosa or labial mucosa, you will have palpable fibrotic bands. The patients can also have reduced tongue protrusion, dryness, altered taste sensation, and hearing impairment can occur because of involvement of eustachian tube. And the patient can also have vesicles ulceration, a retracted or a shrunken uvula which looks like a bud. That was all about reactive or inflammatory white lesions. Now let's move over to infectious white lesions. We have three conditions in this category, which is Candidiasis, oral hairy leukoplakia, or mucosal patches. To begin, so we have Candidiasis, which is a very important fungal infection. A detailed description of this candidal infection has been described in my previous video. You can find the description link below. And I'm just going to have a quick gist of this particular condition because it's important for this chapter as well. So the causative organism is Candida albicans, and we can broadly classify oral Candidiasis into acute, chronic, and immunosuppressive associated. And the predisposing factors can anything which is related to immune suppression, extremes of age, long-term antibiotics, long-term of corticosteroids, anything that involves immune suppression such as AIDS, endocrine disorders such as diabetes mellitus, Addison's disease, and any salivary hypogland function such as Sjogren's syndrome. So the clinical features are essentially white plaques, and they have a typical description of cottage cheese or curdled milk or curd-like appearance. The next condition is oral hairy leukoplakia, which is caused by Epstein-Barr virus. And this is essentially seen in immunodeficiency, very typical in HIV patients. So the presence of oral hairy leukoplakia, I can say that it is a prognostic factor in the progression of HIV disease. And this has a clinical appearance of corrugated white lesion, and the most commonly occurring on the lateral or the ventral surface of tongue. And it's usually bilateral in presentation. And the treatment per se just regresses on treating the underlying cause of this condition. And the last one in this lecture is mucosal patches, which is superficial grayish white plaques overlying an ulcerated surface, and it is seen secondary to syphilis. It also appears as diffuse maculopapular eruptions on skin and mucosa, and it is very highly infective lesion. I'm sure this lecture was crisp and concise, and I've highlighted the most important points required for your examination. Still, in case if you have any doubts, feel free to comment below. I'll try my best to answer you. And don't forget to subscribe and ring on the bell icon so that I can give you more useful videos for your exams. All the best.